So in the next 15 minutes, we will try to understand how OCT scores over IVOS and how bifurcation lesions are one very important um, area where OCT can be good. So when we do a bifurcation, it is like a leap into unknown. Sometimes we wonder whether this lesion is significant or not, because the plaque distribution can vary between the main vessel and the side branch. So we are not sure whether the side branch is significant or not. What are the plaque characteristics? There are diameters at three important points which really vary: the side branch, the distal to the bifurcation, and proximal to the bifurcation. What lesion preparation is required? Has the stent opened well enough? Do I need a side branch stent? And what will be the best strategy, single stent or a two stent strategy? Is the stent finally fully optimized when I leave the patient? So all these questions we generally try to answer on angiography, which is kind of a very poor show in a bifurcation lesion, where it's a three-dimensional structure with a side branch overlapping the main vessel and causing difficulty in the final assessments. So limitations are that there is always a superimposition of the side branch. It's a complex 3D anatomy of the main vessel and the side branch. And the virtual histology has shown greater prevalence of vulnerable plaques in the proximal main vessel, often eccentric and located at areas of low shear stress opposite the carina. And sometimes we wonder what this haziness on angio means. And you saw in the last case, the circumflex ostium, they were wondering, I would have probably left it wondering whether to do or not and spend so much time. So angio means that haziness, confusion is always there. What about unopposed struts in the main vessel? So we don't see those on angiography. The malopposition we hardly can see on angiography. So OCT imaging is not that you put in the stent and then you put in the catheter. OCT imaging has to start with a pre-intervention, because we need to assess everything pre-intervention. We need to do OCT imaging while we have two wires in, we do balloons, and then also we need during the procedure. And then post-procedurally, of course, it's very important. So all three steps are extremely important in OCT imaging. For example, let's take this lesion and so if we have this lesion, it has three aspects: the proximal vessel, the side branch, the lesion hair, and the distal vessel. Now, for a operator who's not so experienced, he will think that, look, I have a lesion from hair to hair. If I avoid getting into the main vessel, I'll be able to put a stent from hair to hair. Let's look at how the vessel looks like in this angiogram on OCT. So you have the tightest portion of the lesion hair. You have a distal vessel, which is normal hair. And the main vessel becomes normal only at this point, and you still cannot see the three layers. So from here up to this point, this vessel is abnormal. While you may think that you can get away with a small stent, and these patients end up with the restenosis later on this. This side branch looks good, and you can also see the side branch on the longitudinal section. So you see on the longitudinal signal, the side branch is good. However, if you look at this angle, you see this angle is narrow. You will have to take some care. Even though it's widely open, you may get away without putting a side branch. So this is an important issue on longitudinal view which you get. Now, always we have a question whether we want to put a single stent or a double stent, and bifurcations are challenging in that. So the definition trial study has provided evidence that complex lesions in which specific anatomical malformation as assessed by angiography, where two stents may be required. However, this continues to be a debate, and we still do not have an answer to that. Can OCT solve that issue? So OCT gives you a very good idea of to size the stent. So you do the sizing on the distal vessel of the stent. Now, for example, let's look at this lesion. And this is an acute infarct lesion. This is abruptly occluded here. There is a diagonal coming off this lesion. On opening this branch, you are left with a tight stenosis here, and you see a diagonal now come off. This diagonal, most of us would think a provisional stent is good enough and do not think this is a complex bifurcation that will need two stent strategy. However, if you do an OCT like it is done in this case, you see a tight lesion at point A, which is very clear on angiography as well. On B, you see again haziness, and here comes the other branch. This is right at the branch carina from the main vessel. But if you visualize the side branch, you still see a tight lesion in the side branch which was not seen. This patient underwent a DK crush technique and two stent strategies. So what looked like a provisional stent on angiography turned out to be a two stent strategy on OCT. And this was the final result on OCT. With a DK crush technique, you have the stents and you have the carina, which is very nicely seen, a beautiful carina in this. You see a longitudinal three-dimensional view showing a very big open carina. This patient underwent a follow-up angiogram at 1 year. This is the 1 year follow-up. Look at this angiographic result and look at the OCT result. So it can help you decide whether you need one or two stents. Longitudinal profile and 3D navigation are two important things which we always are careful to look at. So post-stent automatic lumen profile, to look at the expansion, is very, very important in OCT. We always discuss about proximal crossing and distal crossing. So we have studies to help us show on OCT that what an individual thought was a proximal cross was wrong 50% of the time. So we have always tried to do a distal cross in a provisional stent strategy so that we get this alignment on the carina. And if you look angiographically and feel that you are distally crossed, you will be wrong 50% of the time. So OCT is very perfect in telling you whether you are proximally crossed or distally crossed. Let's look at another example. This is an LED lesion. This is a septal. So of course, people don't want to do a kissing in the septal. So this was done and the septal was kind of pinched and very badly affected. So is this jailed side branch a stenosis or an illusion is what OCT can help guide us. So this is from the longitudinal view. This is a cross-sectional area of the septal on OCT, clearly showing you that this was an illusion. So why this illusion? Because OCT is a 3D OCT helps to tell you the optimal side branch treatment and bifurcation. And this was a study which looked at how to assess the side branch. And they said it was an illusion more than anything. So on angiography, you saw the side branch came down in size significantly, but on OCT, there was not much difference. So there was an illusion in majority of cases on the side branch. So based on that illusion, to put in another stent can be a very disastrous thing. So use of FFR or OCT on the side branch when you get that illusion is very important because operator is tempted to put the second stent. So conclusion was this from this study was 3D OCT measurements QCA by angiography always overestimated the jailed side branch osteocytosis, leading to an illusion. So we always thought, why pot? So let us look at this lesion which was treated. This was a lesion in OM, which was treated from circumflex to OM. This was the result after the stent. You see in this part of this vessel, you see a completely malleable stent. And if you see the angiographic result, you cannot make out if it is malleable. You look like a beautiful result. And that's why the importance of pot. And the 3D OCT also has shown when you do a pot, you kind of open some of the struts of the side branch and help to cross with a balloon or wire. So this is the importance of pot, which has been dramatically shown by an OCT. So as I said, malposition in the proximal vessel is important, leading to a mandatory use of pot before and after whatever you do. Now, another important is that stents have different designs, have different types of carina. And where does a wire cross through which cell, distal cell, proximal cell, which part of the carina? There are connectors. And if your wire does not cross through a proper position, you may end up in having a lot of difficulty in getting more hardware through that wire. and you are stuck sometimes. I don't want to say that every wire cross of a side branch will need an OCT, but if you're not able to cross, just put in an OCT and you will know you were going through the wrong branch. Now, 3D construction can also help you understand the side branch. For example, you can see the side branch ostium. In this case, this is the stent in the main vessel. This is the ostium of the side branch, very nicely open. You see the wire has gone through the distal portion of the main vessel struts. So it is important that you look at everything. If you are doing an OCT, do everything. Do 3D, do MLAs, do whatever you can. Look at the wires. Only then you will get a meaningful result. So what about the left main? So can OCT be used for bifurcations of left main? And I think for distal left main bifurcation, OCT is superior to intravascular ultrasound. And the opinion of the Euro intervention 2017, it is recommended that IVUS OCT or OFPI should be used during an elective PCI of left main. So initially it used to be only IVUS, now it's OCT added on to IVUS. And we also clearly see that Euro intervention, the European guidelines clearly see that OCT, when you are using, do before implantation, during implantation, rewiring, evaluation of results during implantation, and after implantation. So many steps are required. If you do all this, you will get a great result. And it takes another 5 minutes to do all that. We also have to understand that the balloon margin sometimes overhangs, and we sometimes pull the stent balloon to repeat an inflation. So OCT can guide you very nicely of the proximal blocks. So let's look at a left main bifurcation lesion. In this view, if this is an LAO-caudal view, if you ask me angiographically, it's an ostial LAD and ostial circumflex. Left main looks pretty good and clean. And many people would think 011 is what it is. You can just do a good V stent, or you could just do an SKS and get away with a fast result. But let's look at the examination. So we dilated both with a scoring balloon on the circumflex ostium and the LAD ostium, and then did a OCT examination. This is a pullback. This patient had a previous stent in the proximal LAD. This is the pullback from the LAD lesion. You can see the stent, the distal portion looks good, and then there is a dense neo-intermittent hyperplasia or neoatherosclerosis, and we come into the left main, and you see the proximal part of the left main. There is a huge calcium nodule, which was not recognized at all from what we saw on the angiography. And this was pushing the left main significantly. This is what we see from the LAD ostium. This is dense neoatherosclerosis with stent also not well expanded. So we saw that this portion of the stent was far more expanded than this portion, giving rise to neoatherosclerosis. This patient underwent DK crush, and you see the wire. We are trying to go through the proximal struts. So we have gone through the proximal struts, and we examined this on OCT. So you can see this has been a proximal cross. So before we go on to do the next step, we understood that this was a proximal cross. We put in the second stent, and this is before the final kiss. You see the proximal wire into the circumflex. This is the wire. You see some hanging struts of the circumflex stent. This tells you the kissing balloon is not complete, because you want to have a very good opening here. You don't want to see the struts on the mouth of the circumflex. And this is the final kiss. This is the angiography. This is the pullback after the pot on the left main, which was 5 also. And you see the left main looked rather nice on this view. And this is the ostium of the circumflex, which was about 6.5. So there is another view, which is the fly-through view. For example, in this case, if you see the fly-through view, this is the side branch wire, which is going through the struts. And if you crush this part with a kissing balloon, this portion of the circumflex struts will go and hang against the LAD. And if you change your wire position, as has been done, this is the wire now coming through this part, you will get openings like this because you push these struts now towards the circumflex wall, not against the LAD wall. So these simple things are initially difficult to understand, but once you start doing it, you start using this fly-through views, the 3D construction, bifurcation becomes really nice and good to do. This is what finally it looked like, the mouth of the circumflex after a DK crush stent. The LAD and left main stent look excellent. And this is the carina, which looks good in this patient. Lumen areas are the final thing that you have to apply. And you have to look at everything, the edge dissections, the intrastent plaques and thrombus protrusions. And we have been in several examples which we could see some white thrombus, and we had to use GP2B inhibitors in those patients when we were doing some left main stent. Small thrombi you sometimes see, which is very important to identify. You have to see malposition, the reference lumen area at these points. And I thank you very much for being attention on a Sunday morning in such a difficult time. Thank you very much.
Thank you very much, Balbir. And I think there will be questions at the end. We have 15 minutes for question answer session, so just stay back.